Thank you, chairpersons, and good afternoon to everybody. Thank you to the entire Inaugural Committee for the opportunity. So I've been entrusted with the difficult job today of talking about viscoelastic hemostatic assays. Before I start, can I have a show of hands how many of us here are using VHAs on a regular basis? So I see less than 10% of the crowd who says it. And this is what we will be coming to when we traverse certain areas one by one. We'll go through the background, we'll go through what the variations are, why we are talking about this, what the real world data is, and I'll try to put in a simplistic algorithm as to how it can be used. So this is what we have been taught from our high schools of how a coagulation cascade looks very linear, goes step by step. But the problem in things in life are not always supposed to be linear. And these coagulation cascade pathways are at best kept to medical textbooks. Coagulation in normal, not only in cirrhosis, is complex. And it's not a unidirectional procedure or concept. It has been understood that it is non-linear and has an interaction of multiple axes of enzymatic coagulation, fibrinogens, platelets, and a whole lot of other factors. This is for the general coagulation pathways altogether. When it comes to cirrhosis, we have a different problem. On top, we have got a normal situation. When you have cirrhosis, you have got both your factors which are going down. And this is what's known as the concept of rebalanced coagulation. But the rebalance is at all levels. You have a rebalance at primary homeostasis, you have a rebalance at secondary homeostasis, and you have a rebalance at fibrinolysis. So bleeding during procedures in cirrhosis has got multiple axes at play. It's got portal hypertension contributing to it, you've got mechanical trauma, you've got puncture site bleed, and what the topic of interest today is procedure related bleed. We would have been very happy if this were all discrete individual entities. But again, just like the coagulation cascade, these are not linear and these are all interlinked to each other and predict what the possibilities of bleed for any patients undergoing procedure can be. So this is what we are looking at when we see our conventional testing for the 90% of the population who are not using any viscoelastic testing. You're looking at just the tip of the iceberg. PT, INR, fibrinogen levels are also something which are not regularly looked at. So what you're going to look for is something which gives you a global measure of your entire coagulation pathway. And this is what viscoelastic hemostatic assays are, and I'll take you through what these are. There are multiple variations which are there in the guidelines. These are the guidelines that are there. You see the AGA, which says no correction of PT-INR is required. You see the similar things being followed by the ACG. For platelets, if you are more than 50,000, you can go ahead. For fibrinogen, one guideline recommends fibrinogen levels, rest do not. The Interventional Society Radiology Guideline, they are the only ones which divides that you also have to assess the procedure risk, whether it's a low risk procedure or a high risk procedure. What is a low risk procedure? Where based upon expert consensus, your rates of bleed is less than 1.5%. And it's a high risk procedure if its rates of bleed are more than 1.5%. So you need to divide whether it's a high risk or a low risk procedure. They are the only guidelines which give some recommendation that if you have a low risk, you can go ahead irrespective of the prothrombin time or INR. If it is high risk, your cutoff is 2.5. For platelets, if the procedure is low risk, the cutoff is 20,000. If the procedure is high risk, the cutoff is 30,000. And again, they bring in a fibrinogen cutoff. None of these guidelines talk about viscohemostatic assays or viscoelastic testing. So the differences in guidelines also translate to what clinical practice differs by. The study came out from Australia where you are asked, do you have practices for transfusion available at your hospitals? And this is GI, GI radiology, GI surgery. 37.5% had no established practices. When they were asked, when will you transfuse platelets? Even for low-risk procedures, 62% said yes, even with a platelet count of more than 50,000, I will transfuse platelets. You go to FFP transfusions, even when you have less than 1.5, 19% would have transfused, and even between 1.6 to 1.9, 67% would have transfused. So your guidelines are not at par, your practices are also not at par. But in contrast to that, what is the actual rates of bleed that patients with cirrhosis have? This is the largest data set till date available, which is the PROC bleed study. 1,000 plus patients, 3,000 plus procedures, only 93 procedure related bleeding events. Out of them, major bleeding less than 1%. What predicted? BMI, MELD, presence of ACLF, infection, AKI, history of CKD. Overall predictors, BMI, MELD, high risk procedures. So given this low rates of bleed, we still have those practices of more than 60% to 70% prophylactic transfusions in patients with cirrhosis because there are no established guidelines. We go to what those principles of viscoelastic homeostatic assays are. This is for residents, this is how it looks like. This looks complex, but what you want you to simplify is, you've got a first part of the graph, which is how fast is clot you're forming. You've got a second part, which is how strong it is. And the last part, that how long your clot formation is going to last. You've got three principal ways that you can do it. There are three different podiums or ways to do it. One is a rotum, one is a sonoclot, and most commonly available is TEG. If you look at the left-hand side of the picture, the rotum and TEG are very similar. They give very similar graphs, but the names that you have for coining each other are different. You look at the down part, you see three primary things that you're going to look at. And when you want to compare it to your standard test, you compare it to what it looks like too. You've got a reaction time, which sorts of if you're old PT, you've got a maximum amplitude, which reflects fibrinogen and platelet, and you've got a lysis, for which your conventional tests have got no replacements. So these are the very basics of what these viscoelastic assays look like. But one thing that you should remember, that this also accounts for endogenous heparinoids. Patients with sepsis, SIRS, ACLF, they tend to have these endogenous heparinoids, which has to be corrected. So if you've got a long R, always think of using an heparinase which will correct for these endogenous heparinoids. Real world data with use of VHAs. Invasive procedure, central venous access. Propensity matched analysis shows maximum use of FFPs and cryos and platelets, no differences in bleeding rate. You go to use of platelet transfusion, the study coming out of All India Institute, no differences, and TEG leading to reduced use of blood products. You go to the other strategies for post-transplant variceal bleeding, overall invasive procedure, you've got different strategies, all of them convey the same message that it reduces requirement. Are these strategies perfect? We still don't know. That is what Dr. Madhumita had tried from PGI to validate these strategies as to which is possibly a better strategy to go ahead for individual factor replacement depending upon the values of TEG. And when we start to use these modalities, we would have to validate these in individual settings. So the first question, does VHA reduce transfusion requirement? The answer is an overwhelming yes. Both platelets and FFPs, there is no doubt about it that it reduces transfusion requirements. But there is a second question, that does VHAs improve outcomes? Where the answer is a question. We still do not have good validated data. The TEG doesn't reflect other parameters like protein C, VWF. We don't know about outcomes beyond transfusion. Every study has focused upon transfusion volume, transfusion volume, transfusion volume. What about exact bleeding rates? And now the PROC bleed data has shown you that the bleeding rates are less than 1% of significant bleeding. What about reactions? What about death as an outcome? So we need to reconcile with this large data and try to see how these work when you restrict it to only high risk procedures. because given the very, very low risk in patients with low risk procedure, it is going to be take tens and thousands of people to have a single good randomized trial to have even definitive outcomes. So these are things that we need to keep in mind while we use VHA in testing. And the last part is that, as you all said, that less than 10% actually have access to these testing strategies. So this is why the recent expert recommendations for correction of coagulopathy prior to procedures again do not mention anything about viscoelastic testing. But since the topic assigned today was whether and how you can use it, I become provocative and I give you a simplistic possible TEG-based algorithm, which is that if you have got a low risk procedure, perhaps you do not even need to use a TEG. You can proceed, use ultrasound, you have trained operators, avoid arteries. What I don't know is that the procedure is low risk, but the patient has established coagulopathy. We do not have clarity on that. If the procedure is high risk, you use TEG-based strategies depending upon your R and your MA, whether you transfuse FFPs or platelets. And the last part, if you're actively bleeding, then in combination with your clinical judgment, use of TEG or ROTEM can help you to reduce the amount of transfusion. So we summarize. What is things that are established? Procedure-related bleeds and cirrhosis is complex. Conventional testing is inadequate. We need to classify our procedures according to their individual risks. VHAs definitely reduce transfusion requirements. What needs to be established is the use of VHAs has to have a greater access and validation. We can modify these VHAs like using heparinase for better accuracy, and the translation to endpoints beyond only volume of blood product requirements needs further validation. Until then, the approach remains individualized. Thank you, everybody.